Hello, my name is Leslie Scoutt, and I'm a professor of radiology at Yale University School of Medicine, where I am Chief of Ultrasound at Yale New Haven Hospital. And I'm excited to be talking to you today about ultrasound evaluation of the carotid arteries. It's a subject that's very dear to my heart and something that I'm very excited about because it involves not only imaging but also pathophysiology, so it's extremely interesting. In addition, it really offers you the chance to make a significant impact on a patient's health and future, because by diagnosing carotid artery stenosis, you can help prevent stroke, which is a significant worldwide problem. So I'm here to share my experiences and the things I've learned over the years, and I hope that these will help you in your practice and help improve patient care in your area. Thank you. So this next segment will be a presentation of ultrasound evaluation of the carotid arteries. We're going to talk a little bit about the background, technique, and then focus on characterization of plaque, grading of stenosis of the internal carotid artery with peak systolic velocity criteria, and then finally end up with evaluation of the carotid artery waveform. In terms of background, and to put this topic in perspective, stroke is a major cause of morbidity and mortality in the United States, and it's estimated that there are over 500,000 new cases of stroke per year in the United States in this decade. And it's estimated that approximately 20 to 30% of all strokes are due to disease at the carotid bifurcation. Now, stroke is more commonly caused by emboli rather than ischemia occurring distal to a pressure or flow reducing stenosis. And so the question is, therefore, why do we grade a carotid stenosis if it's an embolic phenomenon rather than being directly related to reduced pressure gradient distal to a stenosis? And the reason is that when you have a carotid stenosis, turbulent blood flow develops characterized by high velocity jets, and these probably contribute to plaque friability. Hence, the risk of embolization is increased, and that risk is directly related to the degree of stenosis. In other words, the higher the stenosis, the more likely there is to be a high velocity jet, and the higher the risk of embolization. In addition, the more plaque there is at a particular location, the more likely it is that it will be irregular or hemorrhagic, and that also increases its friability and its likelihood of embolization. To put it in clinical context, many studies have demonstrated that there is a clear benefit in patients who undergo carotid endarterectomy for hemodynamically significant stenosis in comparison to patients who are treated with optimal medical therapy. And the most common, not the most common, but the three studies that are quoted the most commonly are the North American symptomatic carotid endarterectomy trial and the asymptomatic carotid atherosclerosis study, as well as the European carotid surgery trial. And these three studies were all multi-center prospective studies, and they clearly demonstrated that patients had a significant decrease in stroke and morbidity if they underwent endarterectomy for stenoses in the 60 to 70% range. One of the things, though, I do want to point out that when carotid endarterectomy was compared to optimal medical therapy, this optimal medical therapy at the time that these studies were done in the 1990s really only included antiplatelet therapy as well as diet modifications and exercise modifications. And there are new trials currently underway at many places which are comparing carotid endarterectomy with current optimal medical therapy, which includes oral statins to lower cholesterol levels. So what we all need to pay attention to when these trials are published to determine if this decrease in morbidity remains constant in the patient population that is treated with oral statin medication. Well, with that as background, what are the indications for a carotid ultrasound examination? Most of the time we do this to evaluate symptomatic patients with either neurologic symptoms such as TIA or stroke, or patients who have an audible cervical bruit. In addition, we're often asked to screen patients prior to undergoing cardiac surgery, and increasingly to screen high-risk patients because of many comorbid factors such as obesity, hypertension, and known elevated cholesterol level. We frequently do carotid ultrasound examination to follow up a known stenosis or to follow up a patient who has undergone carotid endarterectomy or carotid stent placement. Well, what is the technique of the examination? There are three basic components of this exam. First of all, we want to characterize the plaque. Then we want to do the Doppler part of the exam to grade the stenosis in the internal carotid artery using peak systolic velocity criteria. And finally, we want to evaluate the waveform. We perform these examinations with the patient supine, with the head slightly hyperextended and turned slightly to the contralateral side. You can interrogate the carotid arteries using either an anterior or a posterior approach, but whatever approach you use, it is very important that you use the highest frequency transducer possible, and if at all possible, to use a linear array transducer, because both increased transducer frequency as well as the linear array configuration increases the spatial resolution of the examination. Now, in a patient who has a short, thick neck or deep vessels, we sometimes have to use a lower resolution, lower frequency curved array transducer in order to visualize the vessels. So as I said, the first thing that we do is to evaluate the plaque, and we do this on both sagittal and transverse images using both grayscale and color Doppler. And we focus our examination on the proximal and distal common carotid artery as well as the origin and the bulb of the internal carotid artery. But we look also at the mid internal carotid and distal if we can see it, as well as the origin of the external carotid artery. And when we evaluate plaque, we are looking to characterize three different things. First of all, the echo texture, and you want to differentiate hypoechoic from echogenic plaque. We then want to look at the surface characteristics of the plaque, and we differentiate ulcers or plaque with an irregular surface from smooth surface plaque. And finally, we want to estimate the percent diameter reduction just using the grayscale and the color flow imaging. And the reason that we look at all things is that several prospective studies have shown that when there is enough plaque to cause a stenosis, if the plaque is hypoechoic, if it has an irregular surface, or if there are ulcers, this type of plaque is associated with an increased risk of neurologic events and increased rate of plaque deposition. So these are important things to recognize. So here are some examples of different echo texture in plaque. Now, on the slide on your left, you can see this almost completely anechoic or black plaque at the origin of the internal carotid artery, and this would be described as hypoechoic plaque, whereas on the slide on the right, you can see this very bright echogenic plaque at the origin of the left internal carotid artery. This plaque in this patient is very irregular. It's relatively heterogeneous, and it has this focal area centrally, which is hypoechoic, which most likely represents intraplaque hemorrhage, and again, this is associated with a worse prognosis. This is another patient who has very echogenic plaque, both on the anterior as well as the posterior wall, and you can see that that echogenic plaque along the posterior wall casts a very, very dense distal dirty shadow, as indicated by the yellow arrows. And you could imagine that if that plaque were on the anterior wall and you had that shadowing over the lumen of the vessel, it would be very hard to evaluate the lumen, the residual lumen of the vessel. Another couple of examples on the left, again, hypoechoic plaque, and on the right you have some very irregular, more echogenic plaque. It is important to recognize that you actually may only be able to see that hypoechoic plaque on color Doppler imaging. In other words, it may be so hypoechoic that you can't see it on the grayscale imaging. And it will appear as a signal void on the color Doppler image. And here is an example. On the grayscale image, you see a little bit of echogenic plaque, maybe some little internal echoes here in what looks to be the lumen of the vessel. But when you put the color on, you can see that it outlines the plaque, and in fact there's a lot more plaque there, much of it very hypoechoic, that you would not have suspected from the grayscale image. Another example that I've shown you previously, this is that patient with that irregular echogenic plaque at the origin of the left internal carotid, but it doesn't look like it's significantly decreasing the arterial diameter. However, when you put the color on, you can see that in fact there's some color blooming that overrides and hides the plaque that I showed you on the grayscale image. But if you look up above it, where you could really not see much On the grayscale image, you can in fact see there's a great deal of hypoechoic plaque, which is causing a string sign, and there is at least a 95% stenosis of the mid-internal carotid artery, which frankly you wouldn't have suspected on the grayscale image alone. Here is another example showing some plaque at the origin of the right internal carotid artery, some post-stenotic dilatation perhaps, but again, no significant plaque on the grayscale image. But on the color Doppler image, you can see that indeed there's about an 80% stenosis there and hypoechoic plaque that you didn't appreciate with a grayscale imaging alone. The color Doppler can also be very helpful for outlining the surface of the plaque and will help you differentiate smooth, which is relatively benign plaque, from the more irregular, undermined, or fissured plaque that is associated with a worse prognosis. Here on this patient, you can actually see that the surface of the plaque is echogenic, and indeed it looks very smooth, and this is confirmed with the color Doppler. And again, you can estimate that there is about a 50% stenosis there. And on this patient, however, you can see that the power Doppler demonstrates a very irregular surface to that plaque, probably with some ulcers. And again, you can estimate easily the stenosis of at least about 70 to 80%. Ulcers are a very interesting thing to try and diagnose on imaging, whether by ultrasound or with an angiogram. And even our angiographers know that we're really not very good at differentiating an ulcer from just a very irregular but endothelialized plaque surface. You must remember that an ulcerated plaque is actually a histologic diagnosis, and it doesn't mean just a divot in the plaque, because that can be endothelialized and not be an active ulcer. But nonetheless, on ultrasound and angiography, we describe a divot in a plaque that's deeper than 2 millimeters from the residual lumen as being suggestive of an ulcer. If you actually see on an angiogram evidence of that collar button edema around it, that indeed suggests that there is active ulceration there, but again, we can't be absolutely specific. Nonetheless, if we see a divot in the plaque deeper than 2 millimeters, and here you can see one on the sagittal image confirmed on the transverse image, we do raise the question of ulcerated plaque. Most of the images I've shown you have been sagittal or longitudinal images, and they're really the best way for looking at the percent stenosis, as I've tried to show you the surface of the plaque, and it gives you a good view of the extent of the plaque to look at the echo texture. But don't forget to do the transverse imaging. These are very good for evaluation of plaque burden, and we use them to confirm the findings on the sagittal image and to make sure that we're not off-center and therefore overestimating the degree of the plaque. However, we do not categorize the percent stenosis on a transverse image because it tends to overestimate the degree of stenosis. In other words, as you see on this example, you see a great deal of plaque and the vessel is expanded, but the lumen is still more than 3 millimeters in diameter. So although there's a lot of plaque there, the percent stenosis on the grayscale longitudinal image or color image will be more likely to be in the 50 to 70% range, not in the 80 to 90% range as you might suspect on the transverse image. So we don't grade on the transverse image because again it tends to overestimate the percent stenosis. There are a couple of pitfalls in characterization of plaque that you should be wary of, and the most common and most therefore significant is color blooming, because color blooming may overwrite the plaque and therefore obscure it and underestimate the stenosis, particularly if you freeze your image during systole. And so here's an example of plaque seen very well on the grayscale image, and you can see it decreases the arterial diameter by about 50%, but on the color Doppler images it looks like there's no stenosis at all. So remember when you evaluate plaque to use grayscale and color as well as longitudinal and confirm with the transverse images. Incorrect gain is also a problem, and if the gain is too low, it will make the plaque artificially look hypoechoic, and you can overcall this vulnerable or plaque that you think has a worse prognosis. So make sure your gain settings are right, remembering if they're too low, you're going to think all the plaque looks hypoechoic and therefore more worrisome. And the last thing I want to mention about regarding plaque is fibrointimal hyperplasia. This has been described in the recent literature as a risk factor for cardiovascular disease, And on this patient on the left, you can see that there is diffuse echogenic fibrointimal thickening, best seen always along the posterior wall of the carotid artery, and you always make the measurement along the posterior wall in the common carotid artery. And this patient on the right has more hypoechoic and thicker fibrointimal thickening. And again, the thicker the carotid wall this seems to be related with increased risk for cardiovascular disease. Well, having evaluated the plaque, the next thing we do is move on to pulse Doppler interrogation in order to quantitate the degree of stenosis more accurately. And you obtain a pulse Doppler tracing in the proximal common carotid artery and in the distal common carotid artery. And it's very important that that distal measurement be made 2 to 3 centimeters below the bulb so that you don't make that measurement where the carotid artery widens as it joins the bulb and forms the internal and external carotid artery. We make at least 3 measurements in the internal carotid artery, again at the origin, mid and distal, 1 measurement at the origin of the external carotid artery, and then we measure a velocity or get a tracing in the mid-vertebral artery. In addition to these basic tracings, we also sample and obtain a Doppler tracing at any area that demonstrates focal color aliasing, narrowing, or any area where we see significant plaque deposition. When you make the Doppler tracing, it is absolutely critical that the angle be kept at less than 60 degrees, and that angle ought to be kept constant if possible on follow-up examinations. In other words, you don't want to make measurements at 60 degrees in a patient in January of 2007 and then repeat it at 55 degrees in September of 2007. You make at least 3 measurements and record the highest peak systolic velocity and diastolic velocity, and then you calculate a peak systolic velocity ratio, which is defined as the peak systolic velocity at the site of the stenosis divided by the peak systolic velocity in the distal common carotid artery. A couple of important technical pointers. It's critical that you carefully choose that Doppler angle. It ought to be between 30 and 60 degrees, and as I mentioned, you should try and use the same angle for serial studies. If you make the measurements with a Doppler angle greater than 60 degrees, it tends to artificially increase the peak systolic velocity, and this is an example demonstrating that. This is the same patient on the left. The angle is at 60 degrees, which is correct. The velocity is 143. And here, when that angle is incorrect and at 68 degrees, you can see in the same patient the velocity is increased to nearly 200. So if your angle is too high, you're going to get an artificially elevated peak systolic velocity, and therefore you will overestimate the degree of stenosis. Another thing to be careful about is how you actually measure and calculate that Doppler angle. And there has been some controversy in the literature. Should the measurement be made parallel to the wall, as you see with this red line here, or along these yellow lines parallel to the jet of blood? And quite clearly, the consensus of opinion now is that when you calculate that Doppler angle, you should be calculating it parallel to the jet of blood within the lumen rather than to the wall of the carotid artery. Just like gain can be a problem in evaluating plaque, if the gain is incorrect, it can affect the Doppler peak systolic velocity as well. And this is an example lent to me by Dr. Christopher Merritt from Thomas Jefferson University, where, again, he made a continuous tracing of peak systolic velocity in a volunteer's internal carotid artery. And all he did here was at the beginning, he had the gain up too high so you can see background speckles, and then he gradually turned the gain down till it was too low and you didn't see a very sharp white tracing. And you can see that there was a fairly significant range in velocity from 70 with a gain up too high to 55 centimeters per second when the gain was too low. So again, at the very least, don't change your Doppler gain during the examination. Well, what are normal values that you're looking for? These will be variable patient to patient, but the normal peak systolic velocity is most typically in the United States between 70 and 100 centimeters per second. It decreases as you travel distally down the common carotid and internal carotid artery, but the absolute number clearly depends upon pulse rate, cardiac output, blood pressure, age, and also body habitus. you ought to characterize the waveform as well. And the normal waveform of the internal carotid artery is as you see here, and is characterized by a sharp systolic upstroke, a thin spectral envelope, flow above the baseline, and with continuous forward diastolic flow. Now, in the external carotid artery, the waveform looks quite different. There is substantially decreased diastolic flow, little, sometimes no end diastolic flow, and often you see this early diastolic notch. The common carotid artery, which feeds both of these vessels, has an intermediate waveform and an intermediate amount of diastolic flow. When you're evaluating the vessels above the bifurcation, it's absolutely critical to know whether or not you're looking at the external carotid or the internal carotid artery when you measure the peak systolic velocity. And the absolute best way to be sure that you're looking at the external carotid artery is to identify branches in that vessel. There are no branches in the neck in the external carotid artery. Another thing you can do is temporal tapping, and you can tap over the ophthalmic artery just lateral to the eye, and when you do that, you will see a deflection in the spectral tracing, best seen during diastole. Unfortunately, you can sometimes see that in the internal carotid artery as well, though it's usually not as sharply defined as you see here, and if you compare one vessel to the other, it won't be quite as high velocity in the internal carotid artery in comparison to the external. As I mentioned, the external carotid artery will have a higher resistance waveform with less diastolic flow. It will have an early diastolic notch. It tends to be more medial and anterior and also smaller. To reiterate, regarding the internal carotid artery, there will be no branches that you can visualize in the neck. It is larger, has a lower resistance waveform with continuous diastolic flow, and tends to be more lateral and posterior. So with that as a background as to how you do the examination, let's now focus on how we actually grade the carotid stenosis. And this is based on a simple principle which really forms the basis of all vascular ultrasound, which is the simple equation, namely that flow is equal to velocity times the area. And we extrapolate that to the evaluation of the carotid arteries by saying blood flow is equal to peak systolic velocity times the diameter. And basically what that means is that in order to maintain flow volume, if the diameter of the vessel decreases, the velocity must increase. And this is a beautiful graph of one of the most important experimental studies done in vascular ultrasound, and it demonstrates just what I showed you. Along the baseline is decreasing the diameter. This is velocity along the vertical axis, and the yellow line is what happens to that velocity as you decrease the diameter, and the pink line is what happens to flow volume. And you see that as the diameter decreases, the velocity stays fairly constant till you reach a stenosis of about 50%. And at that point, the velocity tends to increase exponentially, though it maintains flow volume till you reach about a 70% stenosis. At that time, flow volume does decrease a little bit, but velocity continues to increase exponentially. And this is the basis for doing the carotid ultrasound examination. So armed with this information, numerous authors have done studies comparing peak systolic velocity measurements in the carotid arteries with angiography. And this is an example of one such study, trying to identify the appropriate threshold to diagnose a greater than 70% carotid stenosis. And in their hands, the peak systolic velocity that was most accurate for identifying these hemodynamically significant stenoses was 210 centimeters per second, a peak systolic velocity ratio of 3. Now, this was another group, did the exact same study comparing carotid ultrasound with angiography, and they found in their group of patients that the appropriate threshold value was much higher. It was 325 centimeters per second with a ratio of 4. So how do you deal with the fact that you have many reputable scientific investigators who find such widely disparate threshold values for identifying a greater than 70% stenosis? Well, Dr. Ed Grant from California did a meta-analysis looking at multiple studies, And he found the same phenomenon for peak systolic velocity, which I'm showing here, as he did for peak systolic velocity ratio, which is namely that the accuracy stays fairly constant for a wide range of peak systolic velocities. So you can see that a peak systolic velocity of 175 centimeters per second is really as accurate as a peak systolic velocity of 300 centimeters per second for identifying a greater than 70% stenosis. What changes, though, is the sensitivity and specificity. So at these lower numbers, you have a higher sensitivity but lower specificity, and at the higher numbers, you have lower sensitivity but you have higher specificity. And indeed, he found the same thing for the peak systolic velocity ratio. So what can you conclude from this? You can conclude that there is a range of absolute numbers and ratios for any given percent stenosis, and these will be both laboratory as well as machine or equipment dependent. You really cannot accurately differentiate carotid stenoses at 10% increments. In other words, I can't tell you accurately that one patient has a 65% stenosis and another patient has a 72% stenosis. In general, with ultrasound, all of these studies have shown that we tend to overestimate the degree or percentage of carotid stenosis, and they all have shown that we are actually more accurate for detecting high-grade stenoses, which is a good thing because these are the ones that are clinically important. We are much less accurate for detecting lower grade stenoses specifically less than about 50% diameter reduction. But this really isn't a big thing because these are not stenoses that are clinically important. In fact, in other words, you would not recommend operation for these patients. So how do you make sense of this? Well, the way I like to think about it is the following. The criteria that you should use depends upon how you plan to use the Doppler ultrasound examination. If you plan to use it as a screening test and you are going to get correlative imaging in these patients with CTA, MRA, or angiography before you refer them for surgery, your criteria should emphasize high sensitivity and you should use those lower thresholds of peak systolic velocity and systolic velocity ratio. However, if you're going to use ultrasound as a diagnostic test, in other words, instead of an angiogram, the criteria should emphasize high specificity and you should use the higher thresholds. And if you can't make up your mind, this actually helps you in how to interpret the specific numbers that you get. In other words, if the number is very high, the peak systolic velocity is, say, 400 centimeters per second, then you know you're likely to be very specific and you can use it as a diagnostic test and refer that patient to surgery without correlative imaging. On the other hand, if the number is low, if it's 220 or 230, maybe then this is a screening test, and if there are other questionable features of the exam, for example, very little plaque, or if there are comorbid problems such that the patient isn't a great surgical candidate and you really only want to send the patient to surgery if you're really sure that there's a stenosis greater than 70%, then these patients with these lower velocities are the ones that you ought to triage first to CTA or MRA. Another thing to remember about these Doppler criteria is that they are only validated for the internal carotid artery and not for other vessels in the neck. So in order to make some sense and to reach a consensus about these, this wide variation in reported thresholds for numbers of peak systolic velocity and ratio, about 5 years ago, the Society of Radiologists and Ultrasound convened a consensus conference to try and analyze this data. And their recommendations, which most of us now use as at least a starting point for evaluating carotid stenosis, are as follows. They use a peak systolic velocity greater than 230, a ratio greater than 4, and an end diastolic velocity greater than 100 centimeters per second as suspicious for a greater than or equal to 70% internal carotid artery stenosis. If the peak systolic velocity is less than 125 centimeters per second, if the ratio is less than 2, and diastolic velocity less than 40, then there's likely less than a 50% internal carotid artery stenosis. So here are some examples as to how you might use this in practice. And these are relatively old examples because, in fact, nowadays these are really the only time that I get angiographic correlation. So in this patient, the velocity in the common carotid is about 60 centimeters per second, and it reaches about 250, 240 centimeters per second in the proximal right internal carotid artery. And when you look on the angiogram, in fact, you see there's just about a 70% stenosis, as you would expect, using those threshold values proposed by the SRU Consensus Conference. Another example where you see that the peak systolic velocity in the internal is nearly 350 centimeters per second, much higher than that threshold value. So you're anticipating that this will be a higher stenosis, maybe 90 to 95%, which is indeed confirmed by the angiogram. And in this patient, you can do your own angiogram with the color or power Doppler, and it looks like there's about a 90% stenosis, and indeed peak systolic velocity is nearly 400 centimeters per second. And another example, this one is interesting. You see that echogenic shadowing plaque in the anterior wall. You can't see the lumen well, and this is when transverse imaging really helps you. But the vessel is clearly dilated there. There's a lot of eccentric plaque, and the question is, though, really, is the vessel just big or is the diameter actually really decreased? And when you do your Doppler, you see that in the common, the velocity is about 50 centimeters per second, but it's 460 centimeters per second in the origin, the internal. So again, you know this is a high-grade stenosis, and so this patient we would refer directly to surgery and not do an MR or a CTA. Well, that's what I'm going to talk about in terms of the Doppler criteria. But what I want to warn you, and what I want to use as an introduction to the next part of the lecture, is that whatever Doppler criteria you choose to adapt in your laboratory, it is absolutely critical that you always correlate the grayscale appearance and the appearance of the waveform with these Doppler criteria, because there are exceptions to the rule that I just outlined. So what do you do if there's a discordance between what you see on grayscale and the Doppler findings? And this is really when it becomes, I think, the most interesting. What do you do if the peak systolic velocity is elevated, but there's no plaque, so you don't see a stenosis? Well, you should consider the possibility of a tortuous vessel or a contralateral occlusion or stenosis. We all know that the velocity increases around a curve, and when the vessel is curving, it's very difficult to assess the correct Doppler angle because the direction of blood flow changes rapidly. And so this means that we very often overestimate the degree of stenosis or the peak systolic velocity in these very tortuous vessels. And one of the things you can do to help you is you see that the vessel is very tortuous. You see on grayscale there's absolutely no plaque. You confirm that on color. And on the pulse Doppler tracing, remember that any true stenosis ought to cause abnormalities in the waveform, post-stenotic turbulence, fill into the spectral envelope, and bruit. Another thing to think about if you have an increased peak systolic velocity but not really a lot of plaque is that there might be a problem on the other side of the neck, because a contralateral high-grade stenosis or inclusion will increase the velocity opposite to it. Unfortunately, the amount that it increases the velocity is really quite variable and unpredictable, and so therefore the use of that velocity ratio doesn't in fact always compensate. And here's an example. So in the right internal carotid artery, you can see it's occluded. The flow stops here right at the bulb. You have a peak systolic velocity of 260 centimeters per second in the internal carotid artery. This is clearly above that threshold that the SRU proposed of 230 centimeters per second. But when you look at that ICA carefully on grayscale and color, you can see that although there's a little bit of plaque here, the lumen of that vessel really is only minimally narrowed, certainly less than 50%. And really all that has happened is that you have increased flow on the left in comparison because of the occlusion on the right, and there really isn't a stenosis here at all. So when you have a high-grade occlusion or high-grade stenosis or occlusion on one side, you really have trouble using those threshold velocity criteria on the other side. Well, what about the opposite? If you have lots of plaque, but the velocity isn't as elevated as you would expect. Well, think about tandem lesions, long segment stenoses, or a very, very tight stenosis. So here's an example. You have a peak systolic velocity of only about 200 centimeters per second. By those SRU criteria, you would expect somewhere between a 50 and 70% stenosis. But on the angiogram, you can see, in fact, that there's a very tight stenosis. So why was our peak systolic velocity so much lower? Well, the reason was that there was a tight stenosis in the common carotid artery proximal to the internal carotid artery. And so when you have tandem lesions, the velocity will not be as elevated in the distal stenosis. In addition, if there's a long segment stenosis, the peak systolic velocity also won't be as elevated as you would expect for the degree of stenosis, although the diastolic velocity also usually remains high. And this is likely due to increased inflow resistance, and this is proportional, in fact, to the length of the stenosis. So here is an example, and on the grayscale images, I saw a lot of plaque. The color Doppler confirms, in fact, that there's really a long segment stenosis that's quite narrowed in at least 2 places. But even though I sampled very carefully up and down the length of that entire stenosis, the highest velocity I could get was 160, which is clearly below the SRU criteria. But again, looking at this, really you shouldn't have a problem on the color flow imaging in identifying the fact that there's probably a 90% stenosis there. This is an older image of another long segment stenosis, just to point out that these aren't very common. Typically, carotid stenoses are only about 1 centimeter or less in length, and if you see a long segment stenosis, you should consider other etiologies such as prior radiation therapy, carotid dissection, arteritis, including fibromuscular dysplasia. But one of the most important things to remember is that if you have a very tight stenosis, greater than 95% stenosis, especially if it's a long segment, the peak systolic velocity actually will decrease. And if you go back to that experiment that I showed you previously, and you put a line at, say, 110 centimeters per second across that curve of peak systolic velocity, you see that it bisects that curve in 2 places. At about 50% stenosis, in other words, a non-hemodynamically significant stenosis, you could see that with 100 centimeters per second peak systolic velocity. But it also bisects the left end of the curve at a very, very tight stenosis. So what happens is velocity increases exponentially from about 50% to about 98%, 97%, and at that point it decreases rapidly until it reaches 0 when it's occluded. And the only way that you're going to be able to differentiate between the high-grade stenosis on the left-hand side of the graft and the not-so-severe stenosis on the right-hand side of the graft is by looking at the grayscale image and the waveform. So what are the clues to a tight stenosis? Decreased diameter of the lumen on the grayscale or the color image is absolutely key, but also changes in the waveform. You might see something called a knocking waveform proximally or a tardus parvis waveform distally. The knocking waveform, which you see proximal to an occlusion or a high-grade stenosis, is characterized by a very low peak systolic velocity. Here you see this is only about 25 centimeters per second, and little reversed or absolutely no diastolic flow, which, as I presented earlier, is not normal for the internal or common carotid artery, only in the external carotid artery. The tardus parvis waveform is characterized by a sort of old hill or old mountain kind of appearance, delayed systolic upstroke. You don't see that nice sharp systolic upstroke, decreased peak systolic velocity, and this rounded systolic peak. And this occurs distal to a high-grade stenosis. And so you ought to look at these features before you grade a stenosis, and just remember that you can't 100% rely just on the single number. And so here is an example where somebody who was inexperienced with this fell into this trap. This was a portable exam done in a patient in the intensive care unit who had an acute stroke, and this was read by someone with inexperience as being normal because they looked at the peak systolic velocity and saw that it was only 37 centimeters per second, so they figured there couldn't be a stenosis. Well, what you need to do is to compare the left side with the right side, and when you do that, you can see that although they didn't see any flow here, they just figured because it was portable and that it was a poor exam. But if you look at the right, in fact, you can see perfectly good flow in a widely patent, perfectly normal-sized internal carotid artery. So if they could have seen it on the right, they should have been able to see it on the left, and so in fact, there's no flow here on the left. In addition, although that flow is, quote, normal, it's nearly half the velocity of the flow on the right. And the waveform looks totally different. There's rounding of this peak. The systolic upstroke is not right, is not sharp, and there's much decreased diastolic flow. So there's asymmetry in the waveform as well as asymmetry in the grayscale and color flow image. And in fact, this patient had a very tight stenosis proximally. They had an MRA, which shows delayed filling of the intracerebral carotid circulation on the left. And unfortunately, the next day, the patient had a large stroke and completely occluded the left internal carotid artery. And the angiogram showed that the only filling to the left side from the brain came through collateral flow through the circle of Willis on this MRA. And in fact, there's no flow in the distal internal carotid artery. So it is important to recognize that changes in the shape of the arterial waveform do provide clues to other pathology. And that's really what's fun about the carotid ultrasound examination, because if you look at these little nuances, it gives you hints to proximal or distal cardiovascular disease that you're not even looking for or looking at, and it can also help you identify some uncommon iatrogenic conditions. And you can look for changes in systole, diastole, and changes throughout the cardiac cycle. Well, what happens if you see increased peak systolic velocity? If it's bilateral, think of aortic regurgitation, hypertension, thyrotoxicosis, or bradycardia. If it's unilateral and there's no significant plaque or stenosis, think about the tortuous vessel or contralateral stenosis that I told you about already. Well, what about decreased peak systolic velocity? If it's bilateral and the waveform is normal, think about things that decrease the cardiac output. So here is an example: very low peak systolic velocity in the common on the right, in the common on the left, and in the internal on the right, in the internal on the left. The velocity is only 20 to 30 centimeters per second. And that is really not normal. And this is due to ischemic cardiomyopathy, and the ejection fraction is only 20%, and you can see that that left ventricle really doesn't hardly contract at all. And I've mentioned the tardus parvus waveform. Again, to repeat, you have delayed systolic upstroke, decreased peak systolic velocity, and the classic appearance of this rounded systolic peak as opposed to the nice, sharp, pointy systolic peak that I've shown you before. And this occurs distal to a high-grade stenosis. It becomes more pronounced the more distal you sample to the stenosis. And what's fun about this is that the pattern of distribution in the vessels in the neck can help localize where the stenosis is, because you know it has to occur proximal to the vessel with the tardus parvus waveform. So this patient has bilateral tardus parvus waveforms. It affects the right common, the right internal, the right vertebral artery, as well as the left internal carotid artery, so that you know that the stenotic lesion has to be proximal to the left carotid, the right carotid, and the right vertebral. So it's in, guess where? The aortic valve. And this patient has a severe aortic stenosis. This valve barely contracts at all. The lumen is almost obliterated. How about this patient? There's tardus parvus in the right common, the right internal. You have a sharp upstroke on the left, and you have reverse flow in the right vertebral. So this lesion has to be proximal to the right vert, the right common, but it doesn't affect the left side. So you can tell this is going to be a stenosis at the origin of the right innominate artery. How about this patient? The right side has a sharp upstroke, but the left side has tardus parvus. It affects the left common and the internal, but the right common and internal have a sharp upstroke. So sure enough, this has to be on the left, can't affect the right, and so this is at the origin of the left common carotid artery. I mentioned the knocking waveform. Again, just to refresh your memory, low peak systolic velocity, little to reversed or no diastolic flow. This occurs proximal to an occlusion or a high-grade stenosis. And think about atherosclerosis, dissection, vasospasm, or increased intracranial pressure. Here is a patient where you have reverse flow in early diastole, no end diastolic flow in the common. As you go up the common, the peak systolic velocity decreases, the reversal of flow becomes more pronounced. You know there needs to be an occlusion above that, and sure enough, there's a high-grade stenosis with a string sign in the right internal carotid artery. And as I said, this will always worsen as you get closer to the obstructing lesion. So another patient, no diastolic flow in the common, lower velocity in the internal, and sure enough, a nearly complete occlusion in the distal ICA. Another example, this looks completely normal on the left, normal diastolic waveform in the left column, common, but you can see no diastolic flow in the right, and you can see that this gets worse as you go towards the head. Velocity decreases in the internal, no diastolic flow, in fact, markedly reversed early diastolic flow. But if you look on the color image, that vessel is widely open, so the obstruction has to be higher than that. And sure enough, if you look in the head, you can see that there is this dense middle cerebral artery sign on the CT, and there has been acute thrombus of the middle cerebral artery, and you can see the stroke on the CT as well as on the MR. What about if you see that waveform bilaterally? Here you see it on the right and on the left, and again worse in both internals, and this is due to increased intracranial pressure, and you can see here there's been herniation across the midline in this patient with a large stroke. Cerebral vasospasm or diffuse cerebral arteritis can cause the same thing. Well, what about this case? And this will help you avoid making a mistake, I think, if you pay attention to these waveforms. Is this normal or abnormal? This is the left side, and I will tell you that this is a normal waveform. And here's the right common in comparison. And there's no diastolic flow. Well, the sonographer brought me this tracing of the internal carotid artery, and it looked basically normal with low flow and a lot of diastolic flow. It looks like an internal carotid artery tracing. But the problem is that you have this abnormal flow in front of it. And so unless there's a stenosis between this point and this point in the distal common carotid artery, which I could see well and there wasn't, this just can't be right. Because this abnormal waveform with no diastolic flow means there has to be a stenosis up above it in the internal carotid artery. So in fact, this isn't the internal carotid artery. That's a branch. They thought that was the external, but in fact that's not. That's a branch off of this vessel, which in fact is the external carotid artery. So this was an occluded right internal carotid artery. What the text thought was the internal was the external, which had an internalized waveform because the right internal carotid artery was occluded. So when we went back and we followed the distal common, we followed it right up to this obstructing plaque and saw that there was no flow in the internal carotid artery. So again, it can help you not mistake an internalized waveform of the external carotid artery. Some very unusual waveforms that you see quite uncommonly. One is this pulsus bispherians, which is two prominent systolic peaks with an interposed mid-systolic retraction indicated by the arrow. Usually the second peak is higher. This tends to occur with aortic valve disease or hypertrophic obstructive cardiomyopathy. And here's a patient where you see that bispherians pulse, and on the CT you can see that calcified valve, which was both stenotic as well as regurgitant in this particular patient. I've only seen pulsus alternans a couple of times. This is characterized by first a high peak, then a low peak with a regular cardiac rhythm. This tends to be due to intrinsic myocardial disease, metabolic disease, and sometimes impairment of venous return. Well, what about a patient who has reversed diastolic flow bilaterally but doesn't have decreased peak systolic velocity? So it's a high resistance waveform but a normal to elevated peak systolic velocity. This is due to aortic regurgitation, and you can see the regurgitant blood flow here. This is called the water hammer pulse. You tend to only see it if the aortic regurgitation is severe. The peak systolic velocity is normal to increase, but you see reverse diastolic flow in the common carotid arteries. It's always bilateral, but the waveform improves as you go distally. And here is another example where you see this abnormal flow in the common carotid arteries due to regurgitation. And often, distally, you now see there's a normal amount of flow in the internal carotid artery, but you see that bispherians waveform, as I described before. This is a very abnormal waveform, but it's very regular. This is due to the intra-aortic balloon pump, and inflation of the balloon causes that second peak of forward flow during early diastole. And you see a flow reversal at the end of diastole, which corresponds to deflation of the balloon. Occasionally, we get called to the unit in a hurry because there's a acute swelling of the neck when they've tried to stick in a central line, because instead of hitting the vein, they've hit the carotid artery, and they've caused a pseudoaneurysm. And here you see the rent in the carotid artery and this large pseudoaneurysm on the transverse image filling with color. And here's the angiogram. Another example demonstrating the waveform in the neck, which has the classic to and fro pattern, but you only see that if the neck is actually thin, as in a case I just showed you. If the neck is very wide, the waveform can be even normal, but often quite bizarre. This is a patient who developed a pseudoaneurysm following a carotid endarterectomy, and I've included it because it shows that nice typical yin-yang appearance of the color flow in the pseudoaneurysm itself, but it doesn't have the typical to and fro pattern in the neck, and that's because that neck is so wide. Ultrasound can be used to diagnose carotid dissection. This is something you should think about in a young patient who has a stroke or a patient who has neurologic symptoms with no obvious plaque. The waveform can be quite variable, very bizarre, decreased peak systolic velocity, and it depends upon the length, the patency, and the size of the true or false lumen, and whether you're sampling the true or the false lumen. Usually you can recognize it on the grayscale images because you can see the flap. Often it's not as thick as this. More often it's nice and thin, as you see here, and you can see it both transversely as well as sagittally. And this patient shows that, in fact, again, has a couple of abnormalities. You saw that thin dissection. You see velocities, though, are elevated, and there's reverse flow. So they're not elevated probably because the diameter is decreased because of the dissection. First of all, you can see color fills the whole thing. But if it were elevated velocity because of a stenosis, you'd have increased diastolic flow. Instead, you have this high resistance waveform pattern. This looks exactly like that water hammer pulse that I described to you before, and it was present actually, that high resistance waveform pattern and the high velocity in the right side, which didn't have the dissection. And so that should make you think of aortic regurgitation. And sure enough, this was a patient with Marfan syndrome who had an aortic dissection and aortic regurgitation, and the dissection extended into the left common carotid artery. Here's another example demonstrating a nice thin echogenic dissection flap. Both the false and the true lumen were patent, and just to show you how variable that waveform can be. When you see a long segment stenosis with increased velocity and no significant echogenic plaque, look carefully at the wall for an intramural hematoma. And if you see that, particularly if you see it on both the anterior and posterior wall, as you see here, think about carotid dissection, because sometimes the false lumen is not patent, or you just have intramural hematoma, and it will dissect for a long way up the lumen and can cause a long segment stenosis without any obvious plaque. If you see an internal carotid artery that is narrowed but has a very beaded, irregular appearance and tends to involve the mid portion of the carotid artery and distal more than it involves the proximal, think about fibromuscular dysplasia, particularly in your young female patient. And note that because of the multiple tandem stenoses up higher, this patient had a tardus parvus waveform. Well, the last thing I want to talk about quickly is the vertebral artery. This typically has a low resistance waveform with a sharp systolic upstroke, looks a lot like the internal carotid artery. If there's a stenosis, you'll see an increase in peak systolic velocity, as you do here. But remember, the vertebral arteries can be asymmetric in size, and the increase in peak systolic velocity can occur just because one side is hypoplastic. So look higher and see if there's tardus parvus waveform. If you see that, that will confirm that the increase in velocity is due to a proximal stenosis. When you have a subclavian steal, you'll see reverse flow. again, it will be blue or below the baseline or negative. Again, we've just switched the baseline so the negative is on top instead of below. And if you see that, always check the subclavian artery. You'll see high velocity centrally, here 450 centimeters per second. And if you look out in the lateral subclavian or axillary artery, you'll see that tardus parvus waveform. This is a very unusual waveform. It's characterized by this mid-systolic retraction. You see this early, very skinny systolic narrow peak, mid-systolic retraction, then velocity goes up again. It can be above the baseline or below the baseline, and it has been described by somebody, I must say, with a good friend of mine who has a lot more imagination than I do, as the bunny waveform. So this is called the vertebral bunny waveform, and this is a pre-steal waveform. And the spectrum of this waveform changes with varying degrees of subclavian steal, and the deeper the mid-systolic retraction, as you see here, the tighter that subclavian stenosis is going to be. Now, if you do provocative maneuvers, such as to exercise the hand or inflate a blood pressure cuff till the hand is numb and then deflate it, you can actually accentuate that mid-systolic retraction. So this is an example from Dr. Cleaver's article at baseline, that systolic retraction is above the baseline, but after provocative maneuvers it deepens and is below the baseline. So in conclusion, I hope I've been able to demonstrate to you that doing accurate carotid ultrasound can help you refer patients for carotid endarterectomy, and the referral of appropriate patients will result in a significant decrease in the incidence of stroke. Ultrasound evaluation of the carotid arteries is highly accurate in diagnosing these high-grade, clinically significant stenoses in the 70 to 99% range. In addition, you can use the Doppler parameters in your own laboratory, either to maximize sensitivity, which you want to do if you want to use this examination as a screening examination, or to maximize specificity if you want to use the Doppler ultrasound examination as a diagnostic study. So if you want to maximize your sensitivity, you want to use lower numbers as your threshold values. If you want to maximize your specificity, of course, you want to use higher thresholds. But whatever velocity parameters you decide to use, it's absolutely critical that you correlate these velocity measurements with grayscale or color images as well.
Yeah, we got it. Can we pick that one up? No problem.
Okay? But whatever velocity parameters that you decide to use in your laboratory, it is absolutely critical that you correlate these velocity measurements with the grayscale and color images as well as with waveform analysis. Remember that the waveforms in the common and internal carotid arteries should be symmetric, the right to the left. And if you see an abnormal pattern that's high resistance and it's bilateral, consider aortic regurgitation. If it's unilateral, consider distal occlusion or high-grade stenosis. If you see that tardus parvus waveform with that rounded systolic peak, consider a proximal stenosis, and the distribution of that waveform within the great vessels in the neck will help you localize the site of stenosis because you know it has to be proximal to all vessels that are affected. If you see a global decrease in peak systolic velocity in all the vessels in the neck, consider things that decrease cardiac output, hypotension, severe aortic stenosis, and left ventricular or thoracic aneurysm. Well, thank you very much, and I hope my experience and the things that I've learned over the years will help you do carotid Doppler examinations. Sorry, can I do that over?
Yeah, absolutely.
Sorry.
No problem, no problem.
All right. And if you see a global decrease in peak systolic velocity, think about things that decrease cardiac output, such as hypotension, decreased ejection fraction, severe aortic stenosis, and left ventricular or thoracic aneurysm. Well, I hope I've convinced you that carotid ultrasound is exciting and that it is useful clinically, and I hope that the things that I have learned over the years will help you and your patients in your practice. Thank you.